For a perineal urethrostomy, the cat is positioned in sternal recumbency with the table tilted. The perineal urethrostomy can also be performed in dorsal recumbency. So we're going to start by making an elliptical incision around the base of the scrotum and the prepuce. It's important to stay at the junction here and not remove too much or too little skin. I like to use a marker first to make sure that we are incising in the correct area, because as you can see, placing the skin under tension can distort the skin edges and it's easy to get lost. After the skin incision has been made, a combination of sharp and blunt dissection is used with tenotomy scissors to isolate the deep structures. And we are trying to isolate both spermatic cords going to the testes. This is obviously an intact male, as well as the penis itself. And so now you can see that we have the spermatic cord here on the right and the spermatic cord on the left, and centrally here is the penis, some of the retractor penis muscle over the top. So just like a closed castration, we're going to brush off the subcutaneous tissue, spermatic fascia, until we isolate that a little better. Now we are ready to ligate and transect the spermatic cord, and of course this step is not necessary in most cases because most cases will be in neutered males. I'm going to do this in a closed fashion, so we excise all the tunic as well, and we are going to use ligatures. So once that's been completed, we can continue our subcutaneous dissection, and the key point here is to stay as close to the penis as possible. The further away you drift, the greater the risk of complications such as neurovascular injury. We're working dorsally a little further and deeper in towards the pelvis. Some retraction is always helpful. While we are doing our dissection, it is important to keep the tissues under tension. The more tension we can apply, generally, the easier the dissection. Now we're getting close to the ischium, and our dissection extends laterally, and here we are now exposing the ischiocavernosus muscle. This is a pretty dense muscle with cavernous tissue in the middle of it that's firmly attached to the ischiatic tuberosity right there. There is a right side here and of course a left side on the ischiatic tuberosity right here. So these muscles anchor the penis to the pelvis and prevent caudal retraction of the wider aspect of the urethra. And they need to be transected, and I like to transect them right off the bone. And here we are doing the right side. Again, palpate the bone, come right off the bone, and this will minimize the amount of bleeding that occurs because there is cavernous tissue right in the middle of this muscle. So we'll continue our dissection right off of the bone, something that you can actually feel as you are doing the dissection. And here we're palpating the bone to make sure that we've completely released those muscles in the right region. So at this point we're going to dorsally retract the penis, and right under here is one final attachment, that is to the pubic symphysis or the pelvic symphysis, the penile ligament, ventral penile ligament, and we're going to sharply transect this as well. But we do need to continue blunt dissection in this ventral region to release the penis from the pelvic canal. Right here we can see the bulbourethral glands. These are important landmarks because we're going to make our urethrostomy up until this point. So here we're transecting the penis and finding the urethral lumen. This can be a little tricky. We have a Tomcat catheter with sterile lube applied. And you can see it, at least in this specimen, it's catheterizing relatively easily, like so. Feed this all the way up and make sure that we are in the bladder. So this is almost dilated or delineated out our lumen, and we are ready to spatulate the urethra. So we insert one blade of tenotomy scissors into the lumen, stay right on midline, and we're going to very cleanly transect the dorsal surface of the urethra. The urethral mucosa is this glistening, shiny appearance right there. And we're going to continue this spatulation all the way up to the level of the bulbourethral gland. It's important to make this spatulation a very clean transection. So here you can see the glistening mucosa, the glistening uroepithelium, and it's very important to identify this. It can be easy to confuse which layers we're suturing. Release tension, and we're going to suture the skin directly to the urethral mucosa, starting at the roughly 10 o'clock and 2 o'clock positions. So I'm at a partial thickness bite in the skin on the right side. Then with careful manipulation with the DeBakey's as well as the needle itself, we can then identify the uroepithelium of the urethra and take a bite that's capturing about 0.5 millimeter to 1 millimeter of that mucosa. We're going to apply just enough tension to this suture to gently but completely oppose the epithelium. 4 throws, and I do like to do these first corner sutures in an interrupted fashion. So now we're over on the left side at the 10 o'clock position. Gentle apposition, but complete apposition, and you can see how those sutures immediately have opened up that urethral stoma. So the rest of the apposition can be performed with either a continuous pattern or an interrupted pattern, and here we are actually using a continuous pattern. So the washboard, the urethral washboard, is approximately 1 inch long. Completing the left side now, Finally, we ligate off the cavernous tissue ventrally and then oppose the skid margins distally. Here we have about a 12 French catheter, I believe, and it should feed relatively smoothly. This stoma should be quite large. Another test to make sure that we've got an adequate stoma size is to slide mosquito up into the stoma, and it should accommodate the entire jaws all the way up to the joint.